Thank you. Quite the introduction. It's a little hard to follow Dr. Ma, who's kind of saving the world, and I just want to raise chickens, so there you go. I did appreciate her speech, though, her talk, because we have come a very long way since the inception of when I first started doing diabetic education. And the focus has changed a lot to be more patient-centered, or the whole person versus kind of a cookie-cutter, everyone must follow a 1,500 calorie ADA diet. We just know that doesn't work. So actually the changes have been really pretty good. I have no disclosures. Nobody's paying me to promote anything. So the learning, hopefully the things that we're going to cover are basically understanding kind of how far we've come, the diabetes history, myth versus reality. I see people all the time who still believe a lot of things that really aren't realistic. Identifying how people are diagnosed, it has changed over the years. Most of what I'm going to talk about are guidelines from the American Diabetic Association, some from the American Endocrinology Association, and also just from American Association of Diabetic Educators, and just 20 years of dealing with folks who have diabetes. Carb counting has become kind of the thing we teach, and meal planning obviously is a huge part of all of this, and how to manage exercise, which is probably your biggest focus, because it can get really tricky, especially people who have type 1 diabetes. And then medications and their implications. The medications have changed enormously over the years. So again, some good things with that, some bad things, just mostly to do with insurance coverage. A little bit of history about diabetes. Basically, diabetes has been around a very long time. There are some reports even in Egyptian times of Egyptian physicians in 1552 BC who recognized this mysterious illness. And they were like, they noticed these people who were just emaciated, wasting away. They really didn't know what that was all about. And then at the same time, there was also some ancient healers who recognized that people would pee outside and the ants would gather around the pee, and they're like, there's a problem there. That person would die. So jump ahead to 150 AD, and a Greek physician actually described this disease as the wasting away of limbs and flesh and bones into urine. That sounds pretty gross, right? Into urine. So that was kind of a little bit more of a focus. And then around the 1600s, they actually started realizing that there was something to do with this, that this emaciation with people and then this kind of dying pretty fast. So they came up with a job, and the job was water tasters. So what these people did was these folks would come in who were basically dying, wasting away, and they would have them pee in a vessel, in a cup, and the water taster's job was to literally smell the pee, and if it smelled sweet, they would taste it. Yum. So we don't do that anymore, and I'm glad of that. I wouldn't volunteer. But anyways, so they would know again that that person was going to die because they had sweet pee. Around the 1800s and even a little before that, kind of things started to really happen. They actually put some names to this condition. Mellitus is actually honey, and diabetes siphon. So they kind of put the two together, and all of a sudden we have this new kind of term. It really wasn't until the 1920s, though, that things really happened, that people could actually, who had type 1 diabetes, could actually live. What happened was Dr. Frederick Banton, who was a Canadian physician, and he had a sidekick, Charles Best, who was a medical student, and they had been doing some experiments on dogs. And they continued to kind of do this, and they knew there was something to do with the pancreas, and so they actually had created diabetes in one of the dogs, kind of removing parts of the pancreas that they thought were the problem. They took beta cells basically from another dog who was healthy, injected it into this dog who was dying, and he lived. So, we're onto something. But the race was on because everybody was now really intrigued by this and getting involved. And so they were really trying to get to be the forefront of all of this as far as insulin. So in 1922, they actually had a young man who was dying. He was 14 years old at the time. And they took, had been really perfecting this extraction from calves. So they took the cells from the calf's pancreas and injected it into this young man, and he lived. So that was kind of the beginning of people being able to live with type 1 diabetes. So again, we have come a long way since then. The insulins, are being very, they're becoming perfected. We're sure not there yet, but it's a lot better than when I first started in nursing. The needles were longer, and even before that, probably you nurses would know, people had to, boil their syringes. So there's all kinds of stuff that wasn't very good. So things have improved immensely, but the reason is it's really good is because there's so many folks who have diabetes. In our country alone, there's estimated there's around 30 million people who have diabetes. Some of those around probably, there's estimates again, 6 to 8 million, don't know that, but the bottom line is it's an epidemic. They call it the diabesity epidemic in our country. So we do know that being overweight is a risk factor, pretty big one, but definitely not the only one. So there's, around 86 million people who are pre-diabetic. So just as Dr. Ma and some others have mentioned about the DPP programs that are out there, it's kind of the big push, meaning prevention of diabetes. We know it does work based on some lifestyle changes and those, the trial that was done with the 3 arms. So it does work, and actually finally Medicare, Medicaid are getting on board with paying for some of those programs. But bottom line is when people have prediabetes, they have such a very high risk of developing type 2 diabetes down the road. We kind of know that if they do nothing, probably around 15 to 30% of those prediabetic folks will end up with type 2 diabetes in 5 years. So that's a pretty big statistic. I had an endocrinologist one time tell me, she said, having prediabetes and doing nothing is like standing on the railroad track, seeing the train coming, and then being surprised you get hit. So it's kind of that important when people have prediabetes to begin to do something. Myths and management. This is one of my favorite ones. I absolutely cannot have carbohydrates. They are evil. So I have people come in that basically, I'm just going to put the whole thing up here, are starving. So they get diagnosed from their primary care, from whoever. They come to see me, hopefully, many don't, but when they do, some of them are literally starving. They're crying, they're scared to death. They said, I got told I have diabetes and to not eat anything white. That's it. Okay, well, that's helpful. Or absolutely no carbohydrates. You cannot have them. They are bad. So we have to, first of all, dispel that little bit of a myth. Like, no, yes, you can, and these are what carbohydrates are, because there's a lot of misconception about what a carb is. Or I have the other camp that, why am I here? I feel fine. The doctor's wrong because I don't feel anything, and I must feel something if I have diabetes. Not true. But the big thing is fear, I think, because most people know somebody who has had diabetes, got their, had the amputation start, lost their vision, ended up on dialysis. So a lot of folks just feel that's inevitable, that's going to happen. So the big push is, no, it doesn't have to happen. Let's start today by helping to control your sugars. This is another one. I got diabetes because I ate too much sugar. Do you think that's true? Well, you know, what happens when you eat too much sugar? I mean, the research is out there for a lot of things that do happen with the simple sugars, but basically you gain weight, right? It's a lot of empty calories, you're going to gain weight. Weight is the biggest risk factor. So we'll see what happens down the road, but at this point, we can say that basically eating too much sugar is just going to cause you to get heavier. Now that I have diabetes, I need to eat special food. I have to buy all that special food, the stuff that doesn't have any sugar in it. Really not true. Again, sometimes that special food is worse for you, right? What makes food taste good? Fat, sugar, salt. So, you know, they'll substitute things for that. So really it's about label reading, and really it's about portions. I always tell people, you know what, there's nothing you can't have. That's just kind of a myth. What it's about is how much. If you want to have a little cookie, fine, not a cookie. So it's more about that. I can't have diabetes, I feel fine. Unfortunately, that is more often the case than not. So again, I wish people did feel sick, because if they felt sick, they would pay attention, but they don't. It's kind of like, in a way, high blood pressure, right? You can feel pretty darn good with your high blood pressure till you have a stroke. And then it's like, oops, wish I'd have kind of paid attention a little earlier. My diabetes isn't bad because I don't have to use insulin. I think this is kind of coming around a little bit where people realize that diabetes, you know, affects you from head to toe. It's a circulatory issue. And it is a concern always, whether you are on insulin or not. So again, these are the diagnoses for diabetes according to the American Diabetic Association guidelines. And, you know, years ago, these were different. They were higher, actually. So they've kind of lowered the standards for this. Basically, if you have a fasting sugar over 126, a random sugar over 200, or an A1C test. I'm sure you're all familiar with that 3-month average blood sugar test, which has kind of become the big thing in diagnosing. Basically, if it's over or equal to 6.5%, that's called diabetes. Pre-diabetes category, again, for folks who, even when I speak to people who have diabetes, I always ask them, do you have children? Because if you do, they are at risk to develop type 2 diabetes just because of genetics. But basically, prediabetes is going to be 100 to 125 as far as fasting, random 140 to 199, and then this A1C test of 5.7 to 6.4. So that's the window we have to hopefully diagnose, start people on lifestyle changes. The DPP trial, I don't know if you guys are familiar with what the goal was in that trial. Basically, it was the lifestyle arm that had the biggest success was that they had to exercise for 150 minutes a week and lose 7% body weight. That was kind of the outcome for that. And just by doing that, they decreased the risk of developing type 2 diabetes by almost 58% or delaying it for a number of years. So that's why it was such a success. And we know that just like previously we heard, you know, that 5% weight loss, it's significant. So I, you know, often take out my 5-pound fat. I show people, here's my 5-pound fat model, and they're amazed. It's kind of like, wow, didn't know that was that much. So it does matter. Of course, there's differences between type 1 and type 2. Last year I was at a conference where a researcher has kind of came up with type 1, that there's about 6 to 8 different kinds of type 1. Never knew that. I thought that was pretty interesting. Type 2 usually results, again, from insulin resistance, genetics, some other factors. LATA is a latent adult onset diabetes that we see. Basically, that's kind of, I think of it like type 1.5. It's kind of like often someone starts out more type 2, kind of turns more into type 1. And then big increase in gestational. In my practice, where in rural northern Michigan, actually the number of gestational gals I've seen has doubled in the past 2 years. That's huge. Usually it's to do with these gals come into the pregnancy overweight to start with, but not always. So that's just been a really kind of interesting thing to me. Symptoms of high sugars. You're probably familiar with these. Thirsty. High sugars are very dehydrating. Urinating a lot. Tired. That's kind of probably the biggest symptom that people will say, I'm just tired all the time. Blurry vision, dry skin, wounds that won't heal, increased infections, hunger, and weight loss. Those are usually with younger folks, often we'll see the weight loss begin, and that's sort of like, little children aren't supposed to be losing weight. Risk factors, genetics play a pretty big role. So again, can't help your genes, right? Thank you, Mom and Dad. Ethnicity, Native Americans, African Americans, Hispanics, Hawaiian Islanders, Alaskan Natives. So certain groups just have a very high rate of diabetes. Age, older you get, more likely it can happen. Obesity, risk factor, insulin resistance. I have to tell you, I never used to see rarely type 2 in children. Just didn't happen years ago, not very often. It's one of the biggest growing populations, 30 and under, people who are type 2. I saw a 3-year-old who was 101 pounds. So, of course, they sent this young gal down to U of M because obviously there had to be something else wrong, right? Some pituitary or some sort of problem that wasn't just related to her being overweight. At the point that I know, they could not find anything. But when I met this little gal, it broke my heart. I mean, she could hardly walk. She literally couldn't because she had so much fat. Parents never cooked. They lived basically on McDonald's, cheap stuff. So trying to kind of talk to them about, this little gal is headed for trouble. She was already pre-diabetic. Her A1C was 5.7. So not a good thing. But her future is pretty bleak. Hopefully there would be some interventions, which, they were trying to work with the parents, but there was a lot of resistance with that. Kind of like, you're not going to tell me how to feed my child. So Agent Orange, I don't know if you all are familiar that Agent Orange is linked to type 2 diabetes. So anybody who'd been in Vietnam, much higher risk. Smoking. We associate smoking with heart disease and cancer, right? Also associated with diabetes, again, because it increases insulin resistance. Gestational diabetes, again, very high risk later in life to develop type 2. Biggest thing is weight control and getting your sugars or getting exercise. Large babies over 9 pounds also can be a risk factor for those babies as well as the mom. Complications. This is why we try to prevent, right? Not only is it terrible for your health, but the expense of diabetes in our country is enormous. And what speaks? Money. So I think that's too why there's a lot of, a lot more research happening. It's a leading cause of blindness in the United States due to retinopathy issues. Really high rate of having kidney damage. So people who are in dialysis, very often it's because they have diabetes. Leading cause of non-traumatic limb amputations, so circulatory issues. As you all know, diabetes and heart disease, right, very closely linked. So the one statistic, 68% of people that are over 65 and who have diabetes will have a heart attack or stroke. So pretty high risk. Sexual dysfunction, people don't think about that. When I see young men who are in relationships, or even if they're not, I will get their attention by, hey, do you want to continue to have sex? Because if you do, you need to control your sugars. Because let me tell you, buddy, in about 10 years, that fifth appendage isn't going to work so well. So, pay attention, pay attention, pay attention. Try to control those blood sugars, but they're young and they feel okay. That's the problem. And most of these are going to be type 1 folks, but I see it with type 2 as well. Depression, we heard a whole thing about that. I'm really happy that the ADA has really started to recognize that the emotional toll of diabetes is huge. I mean, think about it. You do not escape this. Every day, you have to think about what you're eating, what you're doing. Is my sugar going to drop? Is it going to go high? It never leaves you. So they came up actually with this new term. It's called diabetes distress. So we know that people do develop depression more likely, and they just have this condition where they're just so sick of it because they never get a break. So it's easy to lose weight, right? So I'm just going to let you read this. I found this on Facebook. I just thought it was funny. So get some sun every day for vitamin D and skin cancer. There you go. So simple. How many of you are confused about diets, right? I mean, it changes all the time. It's like, and you are professionals in the healthcare business. You can imagine lay people trying to navigate these waters. They read stuff on the internet. Oh, it must be true because this person has these credentials after their name, even though they might not know what those are. So it continues to fluctuate, to change. So I think, a lot of it is just common sense. Eat more real food, less processed food, eat less. I just heard this Tibetan, or I read this Tibetan saying. It said, eat half, walk double, love immeasurably. So I liked that. I just thought that was a pretty good saying because it's kind of true. So this is my favorite one. Fruit is bad for you. I see people when I counsel them and we're talking about their diet and they'll say, well, I don't have any carbs. I have none. I'm like, really? Okay, well, tell me what you eat. Well, I have lots of fruit and I have, lots of milk, but I don't have any of that bread because that bread's bad. So don't have that. So then I have to, sadly inform them that fruit is a carb. And they want to cry. They just want to throw their head down and say, I give up. What am I supposed to do? So that's where we kind of talk about healthy versus unhealthy carbohydrates. And food is essential to life. You need it. Glucose is essential to feed your cells. You need it. So basically, let's talk about being realistic. This is the marathon. This isn't the sprint. You can go on some crazy diets and you betcha you're going to lose weight. But can you sustain it? So the idea is let's be realistic. Let's talk about what you can do the rest of your life because this is not leaving. It's part of your life. So, according to, again, American Diabetic Association, these are still the current guidelines, and for some of you, you may be like, holy, these are way too many carbs. But again, this is in general, for the general population. We are trying to focus more on people as individuals, younger versus older, activity versus not, so these are just general guidelines. Basically, for women, we still suggest 30 to 45 grams of carb food per meal, plus a couple snacks. Basically around 130 grams to 150 grams for the whole day. So that might, again, sound like a lot to you. Men, they get a little more because they have more muscle, so they need a little more. Again, depends on a young man versus an older man. We're going to give them different guidelines. Young men would get more. So, but in general, 45 to 60 grams per meal, plus a couple snacks. High fiber, obviously, 28 to 38 grams per day, because it does help. Fiber is actually considered a carb. It's a carb that doesn't raise your sugar. So that's why more fiber is important. Of course, the lower fat, lower from saturated fat, which you guys are probably experts at. And then, again, the individualized approach, one size does not fit all. The big thing is to remember to look at the total carbs, not just the sugars. I see people all the time who come in and they're like, yeah, that sugar there, I have sugar diabetes, so I got to look at that sugar. And I'm like, yep, you do. But you also have to look at the total carbs, because that's what this is based on. The new labels that came out last year, are you guys familiar with that? The new labels have an added subset of how much is added sugar, of the sugar that's totally in the carb, how much is added. I had a gal last week, and she just made me laugh because this is so typical. We look at the label, and she says, I said, so show me. What do you do? How do you do this? She said, well, I take that 1 gram of sugar, that 1 gram, and I subtract it from that carb there, and then I take the 4 grams, which was fiber, and I divide it all by 4. And I said, wow, okay, that's a lot of math. And why do you do that? She had no idea. She just thought, well, that's what you're supposed to do. So I said, well, do you take a calculator with you when you go shopping? I mean, because I can't do all that in my head. And she goes, well, no. She goes, that's why I don't look at labels. Yes, indeed. Because they are pretty complicated, right? We try to make it, we assume so much with people. Like, we assume they can read, number one. Many cannot. Or they can read and they don't understand what they're reading. I will go through my whole hour presentation with someone, and we talk, and I think they got it, and then I say, okay, show me the total carbs. They point to cholesterol, and I want to just bang my head somewhere. Yep, cholesterol is important, but that's not what this whole session was about. It was about that other C word. So it's a lot of reinforcement, especially with older folks. They need to hear it over and over and over. And just to keep it simple, so simple, instead of worrying about percentages and all that other stuff on the label, just focus on the things that they need to know at the moment, because they can get pretty complicated. We teach the plate method a lot. So, that little 9-inch plate, basically, that's going to be, half the plate, fill it with the pretty stuff that doesn't raise your sugar too much, and then we have the proteins and starches after that. So this is the part that you're probably most interested in. I wish I could tell you it was simple. It's not, but I kind of keep it simple when I talk to people who are type 1 in particular, and especially, anyone on a drug that lowers their blood sugar needs to probably have a snack before their exercise, and their blood sugar should be well over 100. That's kind of just rule of thumb. They need to have, be aware that they have low blood sugar and to be ready with these types of things. You need to know, as providers and caregivers, what on earth they're taking and what if that medicine causes low sugars or not. Because, and when it peaks, there's a whole bunch of different kinds of insulin out there. Some peak in an hour and a half, some are 24-hour insulin. So what kind are they taking? When do they eat? If they just ate, came to exercise, they're probably fine. But if I ate 2 hours ago and I took my insulin, maybe I took too much, maybe I didn't eat as much as I thought, and now I'm going to exercise, that will lower my sugar. To snack or not to snack? You can probably always err on the side of having them snack so they don't crash. When they are going to really be active and exercising, the types of food you would want would be more complex carbs because they're going to last longer versus just like glucose tabs, which are going to be something that raises your sugar really fast, but then it's totally out of your system pretty fast. So also, what is the safe pre-activity glucose level for you? Now again, if you have savvy people who are used to dealing with their diabetes, they can figure that out. But how many of us have that? Not a lot, often. ADA has also kind of done this, or did this, where we have specific kind of levels that you can kind of target. If somebody's on meds or not on any meds, so meds like metformin that don't generally cause low sugars, or they're on no meds, there's really no specific level. If somebody's on a med that can cause low blood sugar, like the sulfonylureas, the glimepirides, etc., then you'd want them to be sure over 90. If they're on insulin, over 100 at least, 110, 120. If they have hypoglycemic unawareness, meaning they can't feel their lows, definitely even higher than that. So this is Susie, who's very astute. Susie's on glyburide, one of the sulfonylureas. She needs to keep her sugar well above 90 before exercising. She knows that if she exercises for half an hour, her sugar drops about 30 points. It's kind of an insulin sensitivity that she's figured out. So basically, if you add those together, she knows she needs to be at least above 120 in order to exercise for that 30 minutes. Again, though, how many of us have these type of people who are that astute? Some of my insulin pump patients are. They really are. They know what happens when they exercise. Many are not. Basically, before exercise, again, this is keep it simple. Keep them above 100. Have a snack first. If they're around 150, they're probably okay, probably don't need a snack. If type 1, they may need to skip the rapid-acting insulin before they exercise. So again, that's, Humalog, Novolog, etc. Plan ahead. Some of my pump folks, they simply either suspend their insulin or they put it on something called a temporary basal, meaning they get a lot less insulin when they're exercising because they know it affects their sugars that much. So that's what that's talking about. Again, depends on intensity, length, etc., of how much they need to eat, if they need to back off on their insulin. So those are kind of just some guidelines. Again, it seems pretty like a lot of words, but basically always err on the side of running a little bit higher because you know they're going to drop. This one people don't realize is often people who exercise, it lowers their sugar. It can for around, anywhere from up to 20 hours even. So some people who exercise one day actually have a low the next day, and they never correlate it, right? Because that happened yesterday when I did that activity, but it can. Late evening activity, again, you may have some lows during the night. So all snacks aren't created equal. Again, the ones that are going to raise your sugar the fastest are the kind of pure carbs, right? The ones like juice, pop, I even hate to say that word, but pop, things that work really, really fast. The more complex ones are going to be your ones that are going to help to level a little bit longer. Hyperglycemia after exercise. I've had people say, well, that exercise doesn't work. Every time I exercise, my sugars go up, so that can't be good. Well, there are some reasons that can happen. Maybe you ate too much before you came. Maybe you didn't, adjust that insulin. Sometimes you might have a low sugar during your exercising, and then your body kicks in with the Somogy effect, which basically counter-regulatory hormones are released, which are going to raise your sugar. So that can happen. Maybe you really weren't intense enough, so you didn't use as much of the stored glucose as you could have. Or you get a big adrenaline rush because you're running a marathon, right? You're really competitive. So sometimes there's different reasons you can have high sugars after you exercise. It doesn't mean it's not good for you. It is. These are symptoms of low sugars. Again, You always treat a low. Again, you want to treat it with the fast stuff first. I would say fast first, fast first. Candy bar will work. It's just going to work slower because it's got fat in it. Fat delays basically absorption of the sugar. So you want something very, very quick. Irritability is a big one. So a lot of people, in kids especially, we notice that. You know, you can tell a real change in personality, but I'm sure you've all seen the Snicker commercials, right? Where they're, and then they have their Snickers and then they're happy. They've kind of identified different levels of low blood sugar. We always used to say 70 or less was a low. It's just what it was. Now we kind of give it a few levels, 70 or less. If, you know, they're feeling hunky-dory and fine, maybe they don't need anything. Level 2 is under 54, definitely want to treat it. And then level 3 is where you're really having severe symptoms. You always want to treat low sugars, especially, you know, if they're symptomatic for sure. Medications. I know I'm running out of time here, so I'm going to kind of fly through these. But there are so many new medicines out there that we never used to have. And so that's kind of gotten complicated. Basically, there's ones that affect your pancreas directly. There's some that affect your liver to make it so it doesn't push out so much sugar. There's ones that make you use your insulin better. Ones that work in your kidneys to help get rid of extra sugar. And then, of course, the insulins, which have changed over the years. So I'm going to kind of go through these quick. The sulfonylureas are still quite prevalent, at least up where we are. They're not my favorite medications just because they can cause low sugars and they're pretty unpredictable, it seems. But these are one of the first classes of diabetes meds that were kind of available years ago, and they're still around. These are ones you'd want to know if you see somebody's on these, right, that you're going to exercise, potentially low sugar. These we don't see much anymore at all. They're just not very popular, so I rarely see someone on these drugs. These are probably the first-line therapy drugs. So these are ones that, again, affect insulin resistance, work on your liver, basically. Glucophage is the, brand name. Metformin is the one you're probably familiar with. Generally don't cause low sugars. Definitely can cause diarrhea, though. So if someone's first starting this, they may need to be have that potty available, but hopefully that goes away. Inhibitors, the carb inhibitors, these used to be popular years ago, but they caused so much gas and bloating, and people hated them. They did work pretty good, but again, rarely see these. Thiazolidinones, these are ones that can help with insulin resistance and help the body to use the insulin it makes a lot better. Actose is still available. You might have been, if you've been around a while, Avandia used to be the other one in this category. A lot of people were on that, and then it came out as supposedly causing more issues with heart failure, etc. So it got black boxed. That was kind of the death of it. But this one is still around, but there's still a precaution with heart failure because it can cause fluid retention. These are, again, ones that are referred to as DPP-4 inhibitors. These are ones that are based on some research done from gut research, from intestinal research, some hormones that were available that are incretin hormones that basically can affect how your body uses sugar and so forth. That's where these came from partly. So Januvia, Onglyza, Tradjenta, Nicina, those are the ones that are available, but again, they're expensive. They do help with lowering sugar. Sometimes your A1C around, it depends, but 0.5 to 0.8%, which is pretty good. These are the new kids on the block. These are ones that we never used to have. These affect your kidneys. They make your kidneys basically pee out a whole bunch of sugar. And because of that, you're also peeing out calories, so people tend to lose weight on these drugs. Sometimes the big side effect is you're peeing a whole lot. May have more yeast infections, UTIs, because of all the sugar in the urine. These also have become, the last couple years, is known as heart protective. So actually they are recommended as second-line therapy now. So metformin, and then perhaps one of these. There's a whole bunch of combination drugs out there. Even my slides are outdated. Just found out a couple more this week. So that means you take, combination of 2 pills in one. So hopefully it's a little less cumbersome and hopefully cheaper. Injectables, these are, again, we never used to have these. These medications help you in a lot of ways, but one of the things they can do is help you feel fuller faster so that your stomach doesn't empty slower, so people lose weight and their sugars do get better. Big downside can be nausea. Amylin is just a hormone actually produced in your pancreas. Turns out when you don't make as much insulin, generally you don't make as much as this either. This is one of the only medications that we can use with type 1 diabetes along with insulin. These are, again, they're called GLP-1s. These are based on that incretin therapy, hormones basically. These are once a week shots, the Bydureon, Trulicity, etc. The Byetta, Victoza are daily type shots. These again can help you generally to feel fuller, maybe lose a little weight. And then there's all sorts of insulins. I'm going to let you just kind of look at those real quick, but basically know that these are fast acting, so these are the ones that are going to affect your sugar much more rapidly. Afreesia is an inhaled insulin. I have yet to see it prescribed in our place, but I know some folks are on it. I think the big issue is how well is it absorbed. You can't take it if you have asthma or a smoker, etc. But it's an interesting concept. And then there's all sorts of other intermediate fast-acting insulins. These are long-acting insulins that you take basically once a day. And then Tresiba is kind of the new kid on the block for that. This one lasts definitely 24 hours and it has no peak, meaning it's just a very flat type insulin. There's pre-mixed, there's combinations now with the GLP-1s and insulin. The big thing is about, this is what AADE talks about is 7 self-care behaviors. So it's a mixture of all sorts of things besides eating and just, taking your meds. We know that emotional stress and physical stress plays a really big role in your sugars. So it's really about control. I like this saying, the road to success is always under construction, right? It's a day-to-day process. Never give up trying. So that's it.